MDROs are multi-drug resistant organisms. Previously, we've highlighted them the best of my ability. I might have forgotten one or two, but MDROs are multi-drug resistant. So you can't just throw Zosyn at it. It might not work. You can't just throw Vanco at vancomycin-resistant enterococcus. It's not going to work, right? Because it's vancomycin resistant, right? You can't throw like a standard penicillin at methicillin resistant, right? CRE stands for carbapenem resistant, so that's pretty bad. If carbapenem is one of our strongest beta-lactams and it doesn't work, that's not good. We have to then get creative, and we have specially developed antibiotics just for those, right? So the other ones, these special antibiotics we developed, we've put on the other slides, right, in the tables. And we got Acinetobacter and CDiff to talk about. So we got bacteria that can just knock out the antibiotics you currently have, and the way they work is pretty interesting. The bacteria have developed over time. They develop little channels that the bacteria goes in. It's like nope, and they just eject it. Right? They develop little pore channels just to eject the specific antibiotic. Or if the antibiotic attaches to a little receptor site, they say, you know what, I'm not going to make it. So what's the word? That's on you, right? And then we have like we talked about beta-lactams, right? Beta-lactams can be inhibited by beta-lactamases. And then now we developed beta-lactamase inhibitors, right? Such as which antibiotics are beta-lactamase inhibitors? Zosyn, right? You have to give it, yeah, Zosyn or Vanco. But yeah, so Zosyn is an important beta-lactamase inhibitor, all right? There's all these kind of mechanisms that they've done to resist our antibiotics. They've been exposed to it for years, and they've had time to evolve. And then, of course, it's on us. We weren't antibiotic stewards, right? The Queen appointed us an antibiotic steward, and we didn't carry it out, right? We left the carbapenem going for 7 to 10 days, or 14 to 21 days, and it was too long. And then we have carbapenem-resistant enterococci, right? So that's the idea. And of course, all of these require isolation. None of these do not require isolation, right? So all of these require ISO of some sort, whether it be droplet, contact, airborne, enhanced, right? There's all kinds of different things whether you have to use a gown or gloves or bouffant. What's a bouffant? It's like ratatouille, right? You get a little hat. It's like I'm wearing bouffant every time now. All right, so MRSA is our first one, right? So MRSA is penicillin resistant. Methicillin was an old penicillin we don't use anymore, but it's methicillin resistant, right? It's aerobic, so it usually hits the lungs. It can be found in the bladder also. It can be found in abscesses. Usually these are juicy abscesses that will propel you across the room. They are going to be potent, purulent abscesses when they have MRSA. Versus just a regular cellulitis, it's probably MISA, which is methicillin sensitive, right? That means penicillins work against it. It's most commonly found in the nose, like probably 80% of us right now have it in our nose, right? But then it can then progress to a pneumonia. And also people pick their nose and they scratch their armpit, and now congratulations, now you have an abscess in your armpit, and now you can be cool at parties and just, I don't know. Anyways, you have, this wound will be purulent with an abscess, right? 2 in 100 already carry it, like the general population, not healthcare workers. Right? There's different types. You can have community-acquired, which usually isn't as potent as the one you got in a hospital. The one in the hospital, it's been there for a while. I've seen stuff, right? It's going to be there, and it's going to say, it's going to be resistant to a lot more things than just a community-acquired one. But in the community, you can get it with poor hygiene, right? So homelessness. Your pets can give you MRSA. What else? Your skin-to-skin contact, IV drug use, MSM, which is males having sex with males, sex in general can cause the passing along of MRSA. I mean, how many people have you seen with groin abscesses, right? It's either the nail is for the nose or it's something else, okay? And we got hospital acquired. That's and they've been in the hospital the last 12 months. They could be at risk for MRSA, right? Usually, like antibiotic-wise, they say 90 days. That's technically what a hospital-acquired UTI is, or a hospital-acquired pneumonia technically is 90 days. But if they've been in the hospital setting, or if they have like a history of diabetes, cancer, COPD, immunocompromised in any fashion, they're at risk for opportunistic infections such as MRSA, right? Someone goes to a long-term care facility, They might be cohorted with someone that has MRSA that might not have been tested, and they could get MRSA in that fashion. Invasive devices go from the skin where MRSA lives into the bloodstream, right? So they get the skin infection itself, or the collapse can make its way into the bloodstream, and now you have a MRSA septicemia. Okay, and then hemodialysis centers are, these patients commonly get MRSA, so these things usually, everybody gets MRSA swab, they go to the ICU, but if they go to the floor, they should get a MRSA swab to see if they have MRSA where? In the nares, right? So we can treat them for it, right? And then symptoms. So it's an SSTI, not an STI, but a skin and soft tissue infection, right? So they have a pimple, an abscess, a sty, impetigo. They have a profound abscess of some sort, profound skin infection. And then MRSA can go to the bladder, it can go to the lungs as well, right? It can be a surgical site infection, anything on the skin can get infested with MRSA. Here on the right are common places MRSA is found, right? And we are the ones that can transmit it. So how do we avoid transmitting it?
Don't touch it.
Don't touch it, yeah. So you're I can't. There's too much MRSA, right? So you got to wash your hands, right? You can hand sanitize. Oh, what's open? Okay. So MRSA treatment. So you can do non-pharmacological treatment. So if there's something to drain, we can drain it, right? So take out the abscess. The abscess is festering. You take out, you make it unfestered, right? You drain the abscess. You do an incision and drainage, an IND. Right? And they used to give antibiotics for everything. Now they say don't give antibiotics, don't need to. You can decolonize the nose with Nosin, right? So Nosin's for the nose, and it's to decolonize MRSA, to get rid of MRSA. All it is hand sanitizer. So if you take the hand sanitizer after you had a questionable encounter with someone, you just like hand sanitize your nose, you'll be fine. All right? It's just 70% alcohol, that's all Nosin is. All right, and then we got, but it's like lemon scented, so it feels nice. Anyways, we got CHG bathing. CHG is going to decolonize the skin, right? Every patient in the ICU gets it. Most patients are going to a surgery on the floors will get it, get a CHG bath. And then we got MRSA screening. We're going to see if they have it in the first place. If they do have it, we can continue the Nosin, but now we add on bacitracin or mupirocin, which is bacitracin as well. They are used to get rid of the bacteria. They're topical antibiotics. Okay, and then another non-pharmacological way to prevent MRSA is to do isolation. So it's recommended to have a private room. If you can't do a private room, it should be someone with MRSA also. And then, of course, we're washing our hands for isolation, but also we can either be contact or we can be droplet precautions. And it's just like how you start with nares MRSA, then it goes to lungs. You can start with contact for nares and then droplet for lungs, for sputum that you're spewing everywhere, right? So droplet isolation is for MRSA of the what? Of the sputum. And for any kind of encounter, use gloves. But especially for contact, for any kind of isolation, always have gloves, right? You don't always have a gown, but for this, since it started out as contact, you're going to start with a gown, and then you're going to escalate to a gown again. Gloves for both, and what's the difference? Is a mask, right? That's the only difference between the two. And then any option of, what's this, for antibiotics? Yeah. So we have severe infections, so we're going to hit them up with Vanco, which is one of our more potent MRSA antibiotics. And then what else we can do? We can do daptomycin. Ceftaroline is a, what kind of drug is that? It's a cephalosporin, which is what kind of antibiotic? It's a beta-lactam antibiotic, right? So ceftaroline is specially engineered to destroy MRSA, right? And then we have linezolid, doxy, clindamycin, Bactrim, and we mentioned Bactrim's going to work on a lot of things, but it has a lot of bad side effects, right? What are some of the side effects for Bactrim? What is it? Bleeding. If you have, you've got bone marrow suppression. What else? Got liver. It can get destroyed. Kidneys can get stones and get kidney failure. Cause toxic epidermal necrolysis. It can work, but it's not great, right? So these are the antibiotics we would use. And we talked about the antibiotics before and what their unique characteristics were. There was those the antibiotics on the tables beforehand. Now you can just look back and reference to them. Okay. And then complications. So we got what happens when you have MRSA. It's like, well, big deal. Well, it can necrotize. It can cause necrotizing pneumonias. Okay, so necrotizing pneumonias here, right? It can then progress into the bloodstream and cause endocarditis, and endocarditis is really hard to treat. It takes about 4 to 6 weeks minimum of antibiotics, and cellulitis can get really bad. It's a lot more potent to have a MRSA cellulitis than a MISA or a regular cellulitis. Okay, more expensive, and that can then progress into the bone, causing osteomyelitis, and that's hard to recover from. And then MRSA is also found with toxic shock syndrome, which is with tampon use, right? They don't change tampons out, then it's going to cause, it can fester and then cause a widespread toxic shock syndrome. Okay, so this is just recapping our antibiotics and where they work, right? Vanco works where? On the cell wall, right? We got ceftarolines, a cephalosporin, which works where? I'm saying cell wall for everything now. So it also works on the cell wall. Bacterium works on DNA synthesis right over here. It stops folate production. Okay, so that's where so you can visualize again where they're going. All right, so we got contact ice. So for which one? MRSA what? MRSA nares, and MRSA sputum is droplet plus contact. All right, so VRE. So that was MRSA. Now this is VRE, which usually happens because you were treating MRSA. It's also a gram-positive cocci, right? Was MRSA gram-positive or gram-negative? MRSA it's gram-positive, right? Staph aureus is a gram-positive organism, and Vanco only covers gram-positives, so it's all kind of clicking gear. All right, so VRE is vancomycin resistant enterococci. All right, so these are in the entero. Where's the entero at? In the bowels, right? So this is usually indicated with UTIs or maybe a bowel infection. It's going to be hard to get up to the lungs, but it's possible. You get that all the way up to the lungs, right? So it's usually with not proper hand washing and such, right? So it's able to survive the surfaces up to 2 months, VRE. So it's important that they are not colonized with VRE. We give them medications to prevent the proliferation, right? So we'll talk about the medication on the next slide. But third most common, nosocomial infection. First place was which one? It's MRSA. Second place is CDiff, which we're coming to. Okay, so there are 2 different types. One's more virulent than the other, but risk factors, it's very similar. So it's cohorting. You don't usually get VRE in the environment. It's really hard. You have to really dig the soil and really eat it for that to really cause a problem. But yes, you could get it as a farmer or something, but it is more commonly found in the hospital setting. You were in the hospital recently. If you didn't get MRSA, you probably got VRE. Okay, they're very common. Prolonged hospitalization, prolonged antibiotic use with what antibiotic? With Vanco. So Vanco should not be the right option for this MDRO, right? Invasive procedures, someone who's immunocompromised, especially at risk, especially liver failure patients, technically organ transplant, sorry. And then what else? So VRE is found a lot in the ICU because those guys usually are more immunocompromised. They have a lot more going on. They're on steroids, which are suppressing the immune system also, right? So enterococci are found in the bowel, and they can make their way to the bladder or other ways. So signs and symptoms. So UTIs is most common because it's going from the bowel up to the bladder, right? It can cause intra-abdominal infections, right? Pelvic wounds. It's just going from the bowel just right outside, right? It can be a bacteremia. Someone gets a eclampsia. Someone has a femoral central line, right? You want to take the plastic out in the first place, but if they're stooling, and then it's getting up out of the central line, that can cause a line infection, right? And that's bacteremia if it makes its way from the skin into the bloodstream, right? Again, it's more resistant. It's resistant to Vanco, but then also if we keep giving other antibiotics, you can now get what's called VRSA, which is vancomycin resistant Staph aureus. So that's not good either. All right, so treatments. What are we going to do for this? How are you going to fix it? You have to give antibiotics to get rid of the VRE. Otherwise, it'll keep proliferating and it's going to keep developing in the bowels, right? And we can catch it early, right? How do you catch a VRE from the bowels? Swab it, right? It's going to go, right? You can get the little VRE sample and send it down to lab. They used to do it for everybody that came to the hospital, but they relaxed that. No pun intended. So we have VRE surveillance can be something. If you have VRE endemic to your area, it's like really spiking up, they might have to do VRE surveillance to make sure that patients aren't getting it so we can treat them prophylactically. But if they have a VRE infection, they probably have a UTI of some sort. And usually we give combo drugs that are going to, like quinupristin, dalfopristin, which is Sinercid is the brand name, right? This guy is gonna, it can be used for MRSA, but usually we're gonna reserve it for something that's really, really potent like this one, because we have a lot of medications that can hit MRSA besides Vanco, right? So linezolid, daptomycin, those are also for MRSA. They can also be used for VRE, right? Just what's not on there is what antibiotic do you not give for VRE? Vanco. What color is George Washington's white horse? White, right? So please don't give Vanco. Don't select that wrong answer on the test. And then we got UTIs. If they have a UTI, we can hit them up with our fosfomycin, but also doxy and tigecycline are also indicated for VRE. Okay, so yeah, so UTIs are very common, and that's usually where you're going to get the cross-contamination if we're not in proper isolation. And what kind of isolation do you do for this? You're going to wash your hands, you're going to wear your gloves if it's isolation, but what else are you going to do? Right? So no hugs. If you do hug, you got to wear a gown. All right? So gown, gloves is all you need, right? And washing hands, of course. All right, then we got CRE. All right, I mispronounced it earlier. So we got VRE, which is enterococci. This is CRE, which is Enterobacteriaceae, which is a gram-negative. Those other guys are gram-positives, right? This is a gram-negative bug, and usually gram-negatives can be more potent. It just depends on the organism, but the mortality, if you get CRE, is extremely high because we don't have much to kill it with, right? So entero means is where? In the gut. We have gram-positive and gram-negative bugs in the gut. This is one of the gram-negative ones, right? So what else? So we got Klebsiella is pretty popular. E. coli is a popular one that can be CRE. Okay, and there's really nothing that evidence-wise that shows which antibiotic combination is best, but these ones definitely are going to use a combo drug. All right, we're trying to try all we can do to perforate those cell walls to get our bacteria, so get our antibiotic in to kill the bacteria. Right, so ceftazidime, and we add one of the beta-lactamase inhibitors, and then meropenem, then we add another beta-lactamase inhibitor. So it's like adding a carbapenem, which is resistant to, but then we're also adding something just to try to sneak it through, right? And then polymyxin, that's Neosporin. Give an IV Neosporin. Sorry, you don't get like a guy in the back corner like squeezing Neosporin bottles, but no, it's going to be, this polymyxin back in the day, it was used IV. Now they opened up all the books and tried to, ask all the grandpa doctors, what'd you use back in the day? And I used polymyxin. It's like, well, that might work, and it does work, but it's terrible. It perforates, it's like detergent, and it perforates the cell walls, the lipid cell walls, but it also perforates your kidneys. It also perforates your liver, so it's not great. Okay, but we have to do what we have to do to get rid of CRE. And then plasmamycin is a specially brewed antibiotic, just like ceftaroline was a specially brewed MRSA cephalosporin. Plasmamycin is a specially brewed aminoglycoside for CRE. Aminoglycosides cover gram-negatives, right? So that's why it's a aminoglycoside. All right, so and this kind of shows where they fall into play on the bacteria. There's our Neosporin with our guys that has basotracin in there too, but it also has polymyxin, right? Polymyxin topical, and then we also have polymyxin IV that we can give for CRE. Okay.
If someone's allergic to the Neosporin ointment, should they not get the IV?
It's a good question. I don't know. Yeah. So it's probably not, but it's depending if it's just causing like local inflammation from the antibiotic, or is it actually a true allergic reaction? Right? They might do a test dose and see how it is. Maybe they give them steroids beforehand just to suppress the immune response. Okay. So CRE comes up from the bowels, and then it's going to make its way to a UTI usually, and that's going to then require these combo drugs to get rid of the bacteria, right? And then what else on this? So yeah, so we're throwing the whole kitchen sink, basically. We're just mixing things together, and we're going to throw everything we can at it to try to get rid of it. What else was I going to say about this? So that's the idea behind CRE. Let's see here.
I was hoping to order some antibiotics. Oh, of course. What would you like to order? Some meropenem? I'm sorry, I couldn't hear you. What was that? I'd like to order some meropenem, please. Meropenem. Yeah. One of the broadest spectrum antibiotics in existence. Have you lost your mind? What do you mean? Do you have culture and sensitivity data to back up this request? Well, it's pending. Have you consulted your antibiogram? I don't have one. Do you even know what you're treating? Yeah, it's a fever. Are you trying to make a superbacteria? Because this is how you make a superbacteria. No, of course not. Hey, Tom. Yeah, what's up? Dr. Bill wants to treat a fever with meropenem. Huh. Is he trying to create a superbacteria? No, I'm not, I swear. Then I suggest you order ceftriaxone and stop trying to destroy the human race. Pharmacy, I got bugs to kill. Infectious disease. What a pleasant surprise. What can I get you? Meropenem. Yes, of course. How much would you like? All of it. Yes, sir, right away. How come he gets meropenem? He, Dr. Bill, is an antibiotic steward. What's a steward? A steward is someone who's devoted their entire career to the responsible use of antibiotics. Well, I can be a steward. Really? Are you willing to go out of your way to shame every other doctor for using broad-spectrum antibiotics? Yeah. Are you willing to stop ordering Flagyl for anaerobic coverage? That's what I thought. Better luck next time, kid.
So meropenem, carbapenems can lead to carbapenem-resistant enterococci. All right, so Acinetobacter. So Acinetobacter is extremely easy to spread. Acinetobacter lives in fluid, it lives in water. So if someone's on a ventilator, there's all kinds of secretions there that it can proliferate in. It can cause UTIs too, that's also fluid, right? So it's gonna be, that's where it's found mostly. It is gram-negative, so we can give gram-negative stuff to get rid of it. You can get it from the environment, but most commonly it's found in hospital settings, and it can go from ventilator to ventilator to ventilator and spread very, very quickly. So it requires a lot of extra isolation techniques. So we got to wear little bouffants and little foot bouffants, which are called footsies. No, they're not. They're called slippers. And so we're going to have those guys, plus we have the gown, we have the gloves, we have the mask, and of course gloves, right? And there are 3 varieties. There's MDR, which is multi-drug resistant, right? That means they're resistant to 3 different gram-negative antibiotics, which is fluoroquinolones we don't care about, but they also are resistant to some cephalosporins and aminoglycosides, which we said was a really heavy hitter for gram-negatives. So it doesn't work on this gram-negative, right? So that's multi-drug resistant. So we might give a carbapenem, right? So carbapenem is going to be a strong antibiotic to hit Acinetobacter. It covers gram-negatives, so that's going to be one of our first options. But sometimes you have extensively MDR, which is a second type, which is a level up, and then we're going to hit them up with polymyxin again. And next, we're not going to hit with just one Neosporin, we're going to hit with polymyxin B and E, which is technically it's a combo drug called colistin. It's IV, and again, it's very, very toxic, but it might do the job. Tigacycline, we mentioned in passing, it's a tetracycline, and it causes all kinds of bad things. It causes liver, kidney damage, it causes QT prolongation, all kinds of bad things. It's usually reserved for something super serious like this. It also turns everything orange, tigacycline. And then what else? You got pan-drug resistant. There's nothing you can do about that. You can try other antibiotics, but nothing works, right? So you have to get creative. TMP is thoughts and prayers. All right, so CDiff. All right, so CDiff is the diarrhea that keeps on giving. It's going to be, it's spore forming, so it forms a little, it goes out in the environment. You can catch it from the environment. When when Mama Dialysis goes out to the Walmart and looks at all the apples and the tomatoes and the celery and then puts them back, and then you pick them up, right? You can get MRSA, but also you can get some CDiff, right? If you don't wash your hands. Wash your hands how? With soap and water, right? So you got to wash your hands with soap and water to make sure that you get rid of the cell membrane that's around the spore of the C. diff. Otherwise, you get into your gut, If your gut is basic, right, like your basic gut, right, so that's going to make you, when your pH is elevated, when would your pH be elevated? When would you have an alkaline stomach? Yeah, PPIs or H2RAs can lead to CDAD or C. diff associated diarrhea. So we need soap and water to get rid of it. This is second place as far as MDROs are concerned, right? So if you don't use bleach, it's going to stay. Otherwise, you got to bleach the surface. All right, it stays on surfaces up to like 3 months to be active and virulent. It can live in skin folds or healthcare workers' hands. It can be everywhere, right? 50% of hospitalized patients have it. But which ones are actually infected? That's the true story. You don't want to be treating everybody for C. diff because then you're going to cause more C. diff, ironically, right? So C. diff is opportunistic. When all the other bacteria are gone in the gut, it's going to proliferate. But just like right now, as healthcare workers, about 2% of the adult population, so 2% of the world population has C. diff currently. Is everybody infected with it? No. But we want to make sure when we test for C. diff that we're testing someone who has active C. diff. It's causing active infection. Otherwise, we're going to overtreat and you're going to cause more C. diff, ironically. Okay. So the biggest risk factor for C. diff is antibiotic use. Right, and certain antibiotics, like we mentioned, they highlight them in UPS green on the other slides there. Right, so those ones cause C. diff. But the top 5, like Watch Mojo for C. diff, is going to be clindamycin is number 1, and then we got fluoroquinolones, right, and cephalosporins, and really your other beta-lactams can also, but those are really the top 3 that can cause C. diff. Right, and the more antibiotics you use, the higher the C. diff chance. All right, so age greater than 65 puts you at high risk. 80% of those of C. diff deaths are those that are over age 65, sorry. And then over age 85, they got 2 times that. So 160% chance? I don't know. Anyways, it's not good to get C. diff as an older person. Hospitalization, that's where you're going to catch C. diff in the hospital setting from a nurse that didn't wash their hands with soap and water. And they didn't bleach surfaces, they're WOW between uses, right? So a lot of people are not washing WOWs between uses. And then we got, what else? We have immunocompromised would be at risk as well. Okay, what else? We got different toxins that get secreted by C. diff. It's just kind of like H. pylori, how it takes hold of the gastrum and starts proliferating and causes inflammation. It's the same thing with C. diff. It takes hold of the gut, right? It takes hold of the gut and it starts proliferating and causes inflammation. It causes the gut to get leaky, and then now it can translocate into the bloodstream, causing a sepsis situation. Okay, so we can test for these toxins on diagnostic tests. It secretes a toxin in the bloodstream, but also the toxin gets secreted in the stool that we can measure, and then we can see if they have C. diff. Remember, a lot of people have C. diff, so we got to make sure we are stringent on who we give antibiotics, who we don't. The other piece is that it forms not only does it produce a toxin, but it forms a nice little fort. It's like, you want to make a fort? Sure. And they go make a little fort, and they make a mucus fort. It's like, okay, I'm not coming over here again. Anyways, there's going to be a little mucus fort. It's called a pseudomembranous colitis. So pseudomembrane, it forms a little membrane shell, and then that's what gets pooped out, and it looks green, right? So against the bowel, it has a pseudomembrane, and that just gets sloughed off, and then the bacteria form it again. They form another little fort, right? So pseudomembranous colitis is a feature of C. diff. All right, so signs and symptoms of C. diff and treatment and complications. Symptoms, diarrhea. One of the complications is a toxic megacolon, which is the opposite of diarrhea. That's when you're not pooping, right? And the colon just stops at that point because the C. diff has eaten away through the enteric nervous system, and now it just stops, peristalsis at that point, and the bowel gets huge. So that's like a bowel that got removed. Here's an x-ray of another bowel, right? It gets absolutely huge. So it could be constipation or diarrhea, but usually 9 times out of 10 it is diarrhea is what you're going to see. It's watery, it's mucoid because that pseudomembrane. It can be green, it can be brown, it can smell, it cannot smell. Like they had like the Taylor Swift halftime recently. They brought a whole bunch of nurses together and center stage, and they had a bunch of C. diff samples. One was C. diff, one wasn't. And they said, tell me if it's C. diff, and none of them got it right. It was like a flip of the coin whether they got it right or not. That didn't really happen. But it's 50% chance whether you get C. diff or not. It's not based on the smell or the color or the mucus or anything like that. It's just you either have it or you don't, right? You have to have diarrhea. That's usually one of the tests to make sure that it is present. So there's algorithms at many hospitals that says, please don't over test for CDiff. Make sure that they are not on a laxative, because that'll cause diarrhea, right? So make sure they're not on a laxative for 24 hours. You have to make sure it's liquid, right? It's like you send a sample of little pebbles down the lab, we got CDiff. So no, that's not going to be accurate, right? They have to show signs of infection also. They have to have that surge response. They have to have a bowel that is inflamed. How do you know if a bowel's inflamed? Is it going to feel hot to the touch? Do a CT, right? You look at a CT, and the CT shows colitis. They got colitis on CT, like an inflamed colon on the CT, and they have they got watery stool. They also have SIRS. Well, shoot, that looks like CDiff, right? But if they don't have those criteria, then the lab should not be testing it, right? What's the mnemonic there? If it stands, send it back or something. Right? So next to the Taylor Swift arena. Anyways, white count is usually ridiculously high. It's like greater than 40, 50,000. So when you have a white count that high, it's probably CDiff. If it's the other reason it'd be like that if they have like leukemias, if they have cancers. Like either you got diarrhea, CDiff, or you got cancer. It's like, well, I don't know what's worse. But anyways, that's the usually when your white count's incredibly high, right? Usually when you have like a severe infection, it's not going to really hit the 40s, right? Usually the white count will peter out like at 34, 36,000, and it'll start coming down with like a regular sepsis. But when you have CDiff, it's going to skyrocket. And of course, the CDiff toxin we can assess, and colonoscopy you could go in there and get and see. Oh, you see all the pseudomembranes like we saw in the previous slide. That's a sign of CDiff. Right? So the treatment is to stop the causative medication that might be causing it, right? And then 20% will just resolve on their own, which is nice. But we don't want to give antidiarrheals when someone has infectious diarrhea. What's the antidiarrheal example of? Like loperamide or oxybutynin and such. Those are guys who are going to stop the bowels from moving. It's like, I got diarrhea. Can I get the medication? It's like, well, you have infectious diarrhea. Sorry. We got to make sure that it is done its course before we keep that stool locked up, right? And antibiotics, we give Flagyl. Flagyl's an anaerobe. It's going to work great on something like CDiff, right? It's actually the second choice. The first choice is Vanco, a PO Vanco, and it's the only reason why you give PO Vanco ever. Someone's getting Vanco by mouth, they have CDiff. If you go over there to the room to give the PO Vanco and they're not in isolation, something's wrong. All right, so they should be on isolation if you're giving PO Vanco, because you're giving PO Vanco for one and only reason, and that's for CDiff. All right, if that doesn't work, then you're gonna like the Vanco doesn't work, and they did a whole course of Vanco and they come back with CDiff, then you're gonna have to then add Flagyl or metronidazole. That doesn't work. We have a brand new medication that costs like $3,000 for a therapy, which is not very doable, for daxamycin. So it's like you can charge $3,000, or I got Bill. He's in the back here. He can give you a stool transplant, all right? So it's like, so you're like, well, shoot, I'll give you a Bill. How much does it cost? It's like $300, all right? Bill does it for free. He donates stool at the stool bank every other weekend. So, and like I said before, we're in short supply of stool donors. So if you want to make a quick cash, being a stool donor, as long as you don't have infectious diarrhea, you'd be a good candidate. Right? And why would you consider a stool transplant, right? Because if you look at CDiff, they're stooling like 15 times per day. They're up every hour at the most. They're not getting sleep. And then if you get over CDiff, right, and you come for your second hospitalization, the chances of coming back for CDiff is 20%. It's 1 in 5. 1 in 5 patients come back for CDiff. And then after that, then we have 40% come back after the second time. Then after that, the third time, then it's 60% chance of coming back. So it's a lifestyle of just pooping. And you're going, I want to end it. So it's like, well, end it with a stool transplant. All right, so you're going to get, and you can deposit it with a colonoscopy. They can just kind of put it in the cecum there, or you can take pills, or you can take get an NG tube and get, you thought that was hard to clog an NG tube, right? So you can put, you get a fresh sample from lab. It comes in the fridge. It's nice. Anyways, or they can do a colectomy. So obviously doing a colectomy if you have problems like this. That's when you would do a colectomy. All right, but it can lead to severe sepsis, severe diarrhea, severe dehydration. And we know that older people are higher risk for dehydration. We talked about toxic megacolon. Colitis is inflammation of the colon and leads to severe sepsis. All right. What else is here?
You go to the doctor to talk them into giving antibiotics for your coughing fit. They explain that the pain in your throat's a virus.
Antibiotics are not desirous.
But you ain't hearing this, you get all in their face.
Why, this is malpractice, a total disgrace. I'm not leaving this place without a script, my man.
Frustrated and berated, doc throws up his hands.
Day 1,
Citromax pill on your tongue. Protect the bugs in your gut, killed off, son.
Day 8,
Your belly ain't feeling so great, and runny diarrhea straight ruins your date.
Fee, fi, fo, fum. I smell the stench of Clostridium.
Difficile colitis serves your rightus for wasting antibiotics on a virus. Now CDiff's free to grow, no competition. The spores that it sows, fecal oral transmission. In the ED, you'll marinate, while your CDiff straight disseminate. Yo, now this ain't your run-of-the-mill type runs, cause the CDiff germs ain't fun. They're the ones with the toxins, fever, septic shock, and toxic megacolon. Yo, and the spores that they shed in the hospital bed, they dead with Purell gel. What the hell? Use contact precautions, hand washings, hospital personnel. Yo, dog MD, just keeping it real with some blue smelly rhymes and an old school feel. Zombies creeping like Dawn of the Dead. CDiff seeping and spawning to spread. Use antibiotics as intended, and wash your hands now, docs, like you meant it. If you don't buy my advice, at least rent it. Hot mess in your shorts, prevent it.
All right, CDiff.